are.
That's not.
Oh, thank you. Is it 3 people?
I don't know. So I do this like clothing rental thing.
Oh, okay.
So I don't even know where they're from, and it'll send me every month different stuff.
I never heard about that.
Yeah, I like it, and so I just send it back and they'll just dry clean everything. They do to somebody else.
Nice.
I know.
I need to find out about
I
this
know, it's
a little
called
bit more.
So I don't stay in my closet anymore. Good.
So we are in, right?
We're in on there, and you're on here, and this is your presentation, right?
That's right.
Just working on it again.
Yep. Insomnia in children, right here.
I need to listen to this. They sleep most of the time.
How old is your children?
I have a 5 and an 8-year-old.
Oh, definitely. Stay here.
We have resident interviews today.
Oh,
House thinking of me signing into the blue jeans. Here, make sure.
I hope I just
There you go. Smells really good.
I'm late, but got the coffee.
Hey,
It's funny how that works out.
Is anybody on that you can ask if they're seeing?
I'm logging in.
Okay. Yeah, if she's sharing a screen, it shouldn't matter where the cameras are pointing because they're going to see the presentation.
yes. Hello?
Yep.
So you can see it.
Nobody on Blue Jeans. We are here on Blue Jeans. We already
There's
signed
8
in.
participants.
It's eight participants.
Maybe they're on their own link.
Yeah, I can hear you. Yeah, we are already on Blue Jeans.
Oh, I don't know if you can hear participants.
I can hear you on the phone. Are you on Blue Jeans?
Yeah, hit unmute. Actually, no. Actually, you
Okay.
don't have to.
Can you move camera, please? I'm okay here.
Yeah, it's like the audio in the room.
We can see PowerPoint on screen.
You know, I think you might use the remote to use when Janisha and I were in here that one thing.
Hello?
Forever. We were struggling.
Yeah, let me just text you a new. Yes, just 1 second.
Test. So the microphone's on. Volume thing is muted. And you don't have to do this.
And when we pulled it up, it seemed like people could hear.
What link is it for? I will just send him text message.
Yeah, the one we always use
Yes.
on the picture. One of the pictures.
Even before you press this, though, if you might pull it up on your phone, then you can hear it.
Yes, it's here.
Hello.
Hello. Good morning, good morning. Why are you signing here? You guys
Oh my gosh, I'm sorry.
haven't.
Here. Yeah, then we only have to do a little initial instead of all this.
How are you?
I'm good. What about you?
Still breathing.
Breathing, yes, you are.
Somebody asked me, how are you doing? You know, still pretty.
If I said that, be.
You should. You should say still pretty. No judgment.
Get some data
From what?
seizure disorder problem.
You want some cookies?
Yeah.
No way, you're back to that thing?
Yeah, I still do sometimes.
Because sometimes you don't, especially when cookies are involved.
Well, yesterday it was like bagel. Ran over.
Yeah.
Or one cookie. I mean, I'll eat a ton of cookies out, like 2 or something.
I was having, because these are really great. I got like blood orange tea, Trader Joe's, like nice touch to contrast the chocolate.
It's harder to not pay attention in here. It's harder to not pay attention in here. Like the other. Could also on my laptop enter. Which this is.
Why did you like to say you guys have to go to? Does that mean she's not going? Or does that mean we're upper level? You don't have to go. I have to silent this. It is silent. Great.
Good morning.
It's like I have like 18.
I have so many where I just haven't replied yet.
Katarina sent me so many pictures and videos of them.
Oh, when they were at the.
On their residence. That's why the video is mostly me and Katarina.
I watched the sample you sent. That's it.
Hello?
You get featured more than once. See the back of your head, side of your head. Oh, your full face. Is long nose your grand nose?
I think we'll be done with rounds by 1 p.m.
Yeah, what?
Kaylee has to come by and grab something.
Oh, Kylie's coming?
Mm-hmm. Probably just meet her outside. So she doesn't have to run out in the car seat and everything.
Hello, good morning.
Hello, good morning.
It is with great pleasure that I would like to introduce Dr. Emily Singer today. Can you all hear me?
Yes.
Dr. Emily Singer is better known to some of us as Emily Weath before she got married, and she was a medical student with us. I met Emily when she was still a student at Vanderbilt doing her undergrad, and she came to Louisville to do medical school, and then upon completion of medical school, left for Vanderbilt University, where she spent 6 years finishing her child neurology residency and then doing a fellowship in pediatric sleep. We were very fortunate to be able to bring now Dr. Emily Singer back to Louisville. And in Louisville now, she does pediatric sleep. She wears a neurologist hat doing pediatric sleep in the Pediatric Sleep Center with Dr. Centerville at Norton Children's affiliated with the UFL, and then does general child neurology with our group. And so she wears the hat of both a pediatric sleep specialist and a child neurologist. And I believe that she's going to bring really a tremendous expertise in an area that is so needed. Sleep problems are exceedingly common in children, and at least in pediatric neurology, half of our patients that we see have sleep disorders. And she's going to bring this great needed expertise to the state and to the region, and make such a big contribution here. Emily lives in Louisville with her husband and children, and her parents live in Louisville as well. So she is really enjoying being close to her family and serving the greater good, both pediatric sleep disorders and child neurology as well. Along with that, she brings a very, very good attitude to work and is really liked by one and all that meet her. We look forward to Emily's growth within the Pediatric Neuroscience Center, and look forward to all the contributions that she's going to make going forward. Emily, welcome, and we look forward to hearing about insomnia and children today. Thank you very much.
Great, thank you, Dr. Perry, for that introduction. So yeah, I'm very glad to be here with you guys this morning and talking about insomnia in children. I recognize that not everybody listening here treats children. However, a lot of the kind of research that we have for insomnia comes from the adult population. So maybe you can apply some of this to your practice. And if you can't use it professionally, then as Dr. Perry said, childhood insomnia is quite common. So maybe you can apply some of this to your practice. All right, so we'll get started here. Let's see. I have no disclosures. And the objectives of this talk, so I hope to first review normal sleep physiology with you all. I think it's really important to understand how a typical sleep happens, and then to also think about what the differences are for pediatric sleep. And then we'll get into insomnia and talk about some common comorbidities and mimics of insomnia before getting into some pathophysiology. Then we'll kind of focus in on behavioral insomnia of childhood and some treatment approaches for that. So be that behavioral or medication. And I think it's helpful to kind of put this into context. And so we'll kind of have a case that we follow throughout this talk as well. So I'll just introduce the case now. So we had a 3-year-old patient that came to see us in clinic, and he is nonverbal and has a diagnosis of autism spectrum disorder, and he's coming in for trouble sleeping. And the parent reports that he actually falls asleep easily I'll bet with melatonin, so his PDP started that, and he is not having trouble going to sleep right now, but he's having a lot of difficulty staying asleep. So he has these prolonged awakenings between 2 and 3 a.m. each night. And there's no snoring for this patient. He's not mouth breathing. There's no restless sleep reported in the sleep history. When we get some more details about the sleep history, we find out that he typically eats dinner around 6 p.m. and then he'll just kind of run around the house to play. At 9 a.m., kind of the bedtime routine starts. That's when he gets his melatonin medication. He'll do a shower, he'll put his PJs on, and then at 9:30 they move into his bedroom. His TV gets placed on a loop, so it plays Thomas the Tank Engine the whole night, and then the parent kind of rubs his back and stays with him until he falls asleep. And then we see kind of where the problems start to happen. So between 2 and 3, he wakes up, and some mornings he doesn't even go back to sleep. And so then by 10 a.m., he is tired and wants to take a nap, and so they have him take a nap since he didn't have a good night's sleep. And then he'll take another nap after lunch, and that one can be prolonged up to 4 hours. Okay, so with that introduction of our case, I want to kind of think about how we sleep. So this two-process model of sleep is a really good one to understand. So this is basically the homeostatic sleep drive and the circadian wake drive. It's also called process S and process C, if you'll hear it referred to as that. And I like this graph depicted on the right to kind of think about that. So we have our homeostatic sleep drive, and I like to think about that as like sleep hunger that builds the longer we're awake. It's mediated by adenosine, and I always remember that caffeine is an adenosine receptor antagonist, so blocking that helps us stay awake. And if homeostatic sleep drive is only process mediating our wake and sleep states, then we'd probably be more likely to sleep in like 2 or 3 hour spurts. The sleep drive would get, or that sleep hunger would get alleviated, and then we'd wake back up. It would build for a couple of hours, and then we'd go up to sleep. But as we all know, that's not how we actually function through the day. So we also have this second process, and that's depicted on the bottom of this graph with the upward arrows. And that is our circadian wake drive. So that is, you can think about it as our internal body clock. It's adapted to be close to 24 hours and mediated by melatonin. And that persists in the absence of light and dark cycles. So they did studies in Mammoth Cave back in the 1900s where they pull patients away from light and have them just be in the cave, and they would find that they had a circadian timing system inherent to themselves. And so you can see that kind of through the day, this wake drive is kind of pacing with the sleep drive to keep you alert and wakeful. I'll draw your attention to this little dip that happens around after lunch. And that is kind of a time where the sleep drive outpaces your wake drive briefly and kind of produces that phenomenon of getting sleepy after lunch, or in other countries having siestas. And then you can see that the wake drive and the sleep drive kind of get to this peak and then quickly dive off, and the wake drive remains low through the night to allow us to stay asleep. I'll call your attention to this time right here. We call that the forbidden zone, and I think this is clinically relevant when thinking about bedtime in kids. Sometimes I'll have families tell me, you know, I cannot get my 8-year-old to go to sleep, and his bedtime is at 7:30. And so potentially what's going on with that case is that we're asking him to fall asleep in a time when his wake drive is kind of maximally activated. And so it just might not make sense in thinking about this. All right, so to understand a little bit more kind of about the complex processes that keep us awake, we have to understand a little bit about how the ascending reticular activating system works. And so the process of staying awake, this is kind of simplified, but it involves a lot of neurotransmitters. So we use histamine, dopamine, norepinephrine, serotonin, orexin or hypocretin, and acetylcholine all promote wakefulness. And then to have sleep take over, that's really coming from the ventrolateral preoptic area with GABA inhibition. And another kind of clinically relevant thing, if we think about orexin or hypocretin, that is absent or destroyed in patients that have narcolepsy. So that helps us explain why people with narcolepsy have the symptoms that they have and why they're so sleepy. All right, so now we will look at this hypnogram. So this would be a typical night sleep for an adult patient. And you can see depicted on the y-axis, we've got our sleep stages. So REM is depicted in light blue. And then as it kind of descends down, we go through N1 sleep, non-REM 1, non-REM 2, and non-REM 3, or slow wave sleep. And you can see for a typical adult, they kind of proceed through the night, spending more time in that slow wave sleep in the first third of the night. And then as their sleep cycles move through, they start to spend more time in REM sleep. So then we get kind of proportionately more REM during the last third of the night. All right, so how is this different in pediatric sleep? So thinking about from infancy, so infant sleep is actually quite unique. So they spend, where an adult might spend 15 or 20% of the night in REM sleep, infants spend closer to 50% of the night in REM sleep. And when we think about their sleep, we actually think about active sleep and quiet sleep. So they don't even have that mature kind of sleep cycle that we saw in adults. And then go directly into active sleep or REM sleep, which is a lot different than what adults would do. In those first couple of months of life, infant sleep is polyphasic. So it's really just driven by hunger cues. And I think anybody that's had a young child or, a baby recognizes that their sleep is kind of indiscriminate of whether it's day or nighttime. So they will just kind of sleep as needed throughout the day and night. And then by about 16 weeks, about 4 months of age, that neurodevelopmental ability to self-soothe starts to kick in. And so we see some sleep consolidation at that time. And infants are sleeping 14 to 17 hours and consolidating that. And then moving into toddlerhood, so again, the total sleep time decreases, 11 to 14 hours is pretty normal. And we start to see daytime sleep consolidate into one afternoon nap. Parasomnia, so night terrors are really common at this age. And then adolescent sleep, again, further kind of consolidating sleep time down 9 to 11 hours. I think notably this is not, adolescents still need a little bit more sleep than adults. And I think that's important to remember and counsel our families. And then this is often a time where sleep hygiene starts to deteriorate. Adolescents are setting their own bedtimes and falling asleep on their own, and there's less parental oversight. And then combine that with the fact that in puberty, as you hit puberty, your dim light melatonin onset delays a little bit. And so then with social pressures of staying up late and talking to friends, this is a good setup to have like a circadian rhythm disorder, like a delayed sleep-wake phase. All right, so to switch over to insomnia, I just liked this cartoon. I feel like we've all had that experience of needing to get up early in the morning and not being able to fall asleep and just over and over again calculating how much time you have left to sleep. And that's not a very helpful thing that our brains do. So the definition of insomnia is having at least 3 times a week or more, some difficulty initiating or maintaining sleep, problems waking up too early, problems resisting bed, or difficulty sleeping without parental intervention. And that needs to lead to some type of consequence, be that daytime sleepiness, attention and behavioral problems, or irritability in the individual, or it could also be kind of an impairment in social, academic, family performance. So this definition of insomnia really works for adults and children and really gets at the fact that insomnia can create a problem for the entire family. And then I think, as neurologists, it's really important to remember that insomnia, while it's common in the general population, it's even more prevalent in some of our neurodevelopmental disabilities like ADHD and autism, as well as in epilepsy and headache. And it can really lead to worsening morbidity here. So, we might see more seizures for someone not sleeping well, increased headaches, or for kids with neurodevelopmental disabilities. They might have just more kind of externalizing behaviors, more problematic behaviors during the day. And then there's kind of long-term consequences for having insomnia. So there was an interesting study done following kids in a longitudinal manner, and they followed children that had poor sleep when they were less than 3. So they had short sleep time, sleeping about 7 hours or so a night. And then once they reached school age at 6 years, they went ahead and did formal neuropsych testing, and they found that those kids had increased rates of hyperactivity, and they had lower cognitive performance, and that was even if their sleep had normalized by the time that they were doing the testing. So it just suggests that there's this really critical period of neurodevelopment that is kind of impaired if you don't have good sleep. And then two, there's impacts on mood and even family. So they looked at a study where they found children with insomnia were more likely to have moms that had suffered from depression and had poor family functioning. All right, so we'll move now into some pathophysiology. I really like this 3P model for insomnia. I think it's a very helpful one when you're thinking about insomnia in adults or children. And the idea is that you have some predisposition, some genetic predisposition to insomnia, and we'll talk about that a little bit more on the next slide. And then there's typically some precipitating event, and that can be something very obvious. I had a patient that had a suicide attempt, and then after that had really severe insomnia, but it can be something more mild too, some stress in the family and that kind of thing. And then the parent or the patient ends up doing these perpetuating factors. And those perpetuating factors are behaviors that they are hoping to kind of recover their sleep or do better with sleep. And they actually kind of promote insomnia. So that could be daytime napping, that could be lying in bed awake, or adults using drugs or alcohol to kind of cope with sleep loss. And I liked this quote from this paper from Ryman, that normal sleep is an automatic and involuntary process. And when you have insomnia, sleep becomes extremely effortful and extremely intentional, and that can be very problematic. All right, so there is this hyperarousal theory for insomnia, and I think it kind of helps explain that genetic predisposition. And so when they've looked at patients with insomnia, they found that they had increased information processing during light sleep. And so everybody has some degree of information processing during light sleep. And you can think about a time if you fell asleep on like an airplane, or maybe in class you've fallen asleep, or maybe right now you're falling asleep, and you can kind of hear what I'm saying, but you might not be kind of fully awake and processing that. Well, people with insomnia can kind of report more information processing. And so they have this perception, even in light sleep, that they're not actually sleeping. And so that can be problematic. And then they also tend to have more memory formation around the sleep onset. So they are more likely to remember each time that they woke in the middle of the night and have this perception that they're getting worse sleep. And that kind of fuels that issue that I don't sleep while I have insomnia. And then two, they found that people with insomnia have more nocturnal sympathetic activity, and they measured that with increased heart rate variabilities and kind of higher core body temperatures at night. And then experimentally, when you put somebody in the lab and sleep restrict them and kind of sleep deprive them, that they've shown that stimulates the HPA axis and releases more cortisol, so that kind of stresses out. And then kind of objectively, using sleep studies, we can show that hyperarousal is present 24 hours. So of course, when you bring somebody in that has insomnia for an overnight study, you often find prolonged sleep latency, so taking longer to fall asleep, and then spending more time after sleep, waking up and spending more time awake through the night. But we can also look at mean sleep latency tests in individuals, and so judging how quickly they fall asleep during a daytime nap, and they take longer to fall asleep for naps during the day as well. All right, so when we think about behavioral insomnia in childhood, we can apply some of the same things that we learned in the adult insomnia theories, but there's an additional component of behavioral insomnia, and that is the caregiver or the adult that's overseeing the child's sleep. And so these definitions really get back to that point that there's an additional party involved. So there's two types of behavioral insomnia, and you can also have a combined type. The first is a sleep onset association, and that is requiring an environmental condition that needs to be met for the child to both fall asleep and stay asleep. So this tends to present as nocturnal awakenings. And I think the easiest example to think is that, somebody that needs a parent to fall asleep. And so then when they wake up in the middle of the night and the parent is gone, they can't sleep until that parent comes back and reassures them. But this could be, things that are not necessarily a problem either. So thinking about kids that like to sleep with a pacifier or kids that sleep better with white noise machines, those are all sleep onset associations, but just more positive ones that can kind of be maintained. And then the other type is limit setting. And so these are stalling behaviors that the child will do, and it's met with inadequate caregiver limits. And so you can think about like kids that ask for one more story before bedtime, one more glass of water, I need something to eat, I need to go to the bathroom again. So those are all those stalling behaviors. And if inappropriate or inadequate limits are set around those, the child will have a lot of trouble falling to sleep. And then of course you can have the combined type. All right, so before we kind of consider a diagnosis of insomnia, it's important to screen for other sleep disorders. And so, sleep apnea could present as somebody having a lot of nocturnal awakenings overnight. And then restless leg syndrome or restless sleep disorder could present as trouble falling asleep at night. Delayed sleep wakes, same idea, trouble falling asleep at night. And then just screening to ensure that there's sufficient sleep time, that they're getting enough opportunity to sleep overnight, and then there's not a systemic disease or medication side effect that might explain what we're seeing. All right, so we'll move into insomnia treatments. And first I'll talk about behavioral therapies, and then we'll move into some medications. All right, so when we think about behavior therapies, the AASM, so American Academy of Sleep Medicine, the guidelines for treatment of insomnia is behavioral therapy, and that's for adults and pediatric. So I think it's important to understand these. And so really when they came out with the guidelines, they outlined these 5 kind of items that can be covered for behavioral therapy. And the first is pretty simple. It's just parental education. So a lot of you probably already do these things, but talking about sleep hygiene and also some prevention. So thinking about putting your child down drowsy but still awake to help avoid those sleep onset associations. Creating a bedtime routine is really important. So having kind of a uniform, calming, very positive transition to sleep that happens every night and can be relied upon helps you kind of transition, and this is good for adults and pediatric. And then extinction. So this is where you basically extinguish an undesired behavior. So that would be typically bedtime protesting by removing the positive reinforcement that you're getting from caregiver attention. This is also known as cry it out. And it's very effective, and it's, they've looked at it and it's safe, and there's no kind of differences in neurodevelopmental outcomes for the parents that used cry it out or extinction on their children. However, it's really unpopular. So I generally don't recommend this because there's not a lot of parental buy-in, and you really need that to happen to do this. So what I use a lot more commonly is graduated extinction, and it's the exact same principle, but again, it's more gradual. So you're going to ignore that bedtime protesting, that undesired behavior for specific intervals, and kind of increase those as you go. And I warn families that it takes longer because we are doing this gradually, but I typically get more buy-in from families about graduated extinction. And then the last behavioral therapy that can be tried is a faded bedtime. And this is a little bit different than what I talked about before, where you're, when we were asking somebody to move back the bedtime because it was kind of in that forbidden zone. This is more moving a bedtime back temporarily to better match the child's sleep time. So for example, if it was taking an hour and a half for the child to fall asleep, temporarily moving that bedtime closer to where the child actually falls asleep. And then as they get better at falling asleep at that time, you would fade the bedtime back toward whatever the desired or appropriate bedtime would be for them to get optimal amount of sleep. So those are the behavioral therapies, those 5 kind of components. And they are simple, but it is a lot easier said than done. And I think, too, they can be very overwhelming to present all of these to a family, or to kind of just pick out things that you say to every single person. I think, too, that is not as helpful. So I really try to tailor my behavioral recommendations to what the family thinks that they can agree to, and limit it to, one or two things. That can make a big impact if they actually feel like they can do those things. All right, so let's apply these back to our case with the 3-year-old boy with autism. So you could probably argue he has some amount of the combined type of behavioral insomnia, but for the sake of this, we'll just focus on the sleep onset association he has. So he needs that parent to pat him and stay in the room with him to fall asleep. And we see that manifest as the prolonged nocturnal awakenings. And when we screened for other sleep disorders, we did not seem to find anything else. So there's probably not a need to do like a sleep study in him. So our first recommendation would be to try behavioral treatment. And so recommending graduated extinction for this family would probably be the most helpful. And so we're going to ask, them to have a nice bedtime routine, maybe incorporate some of that padding and snuggling into the bedtime routine, but not doing it to the point where he's actually already sleeping. And then asking him to fall asleep in his own room with the parent outside of the room, and the parent can go check in on set intervals on the patient. Importantly, for this patient, I did not ask them to kind of turn the TV off or stop the TV on the loop. I'm trying to change just a few things at first. But what we did ask them to do was to limit the daytime napping. And so providing them education and actually talking through some of the reasons why it's important to build up your sleep drive, I think can be really helpful for families to understand why we're asking them to do the things that we are. So we asked them to kind of wake up at the same time every day, and then to limit that napping to something more appropriate for a 3-year-old, which would be kind of one afternoon nap. All right, so a lot of what I presented so far is going to work well for a young child, but what do we do for adolescents that aren't sleeping well? So adolescent insomnia much more similarly mirrors adult insomnia. So these kids are worrying about sleep, thinking about sleep a lot, and having issues falling asleep because of that, not necessarily because a caregiver is not setting appropriate limits, but that can be an issue too. So I think what's interesting is this study looked at using the first-line treatment for behavioral insomnia in adults and to see if they could apply it to adolescents. So first-line treatment for insomnia in adults is cognitive behavioral therapy for insomnia, CBTI. And this is administered by a professional. It's a series of about 4 to 6 sessions where they really kind of hone in on how a patient is sleeping. They spend some time thinking about like reporting sleep schedules and understanding what their sleep efficiency is, and then helping them retrain their brains to allow for sleep to get back to that place where it was kind of automatic and not so intentional. And so for this study, they took adolescents, so 13 to 18-year-olds, and they randomized them into a wait list group or an internet treatment group or a group treatment, so in person in groups. And you can see from this graph that the adolescents that got treatment in either arm really improved their sleep efficiency, and it stayed improved even at follow-up. So I think this is a nice option. However, there's a big access issue. So we don't have really access to CBTI in our clinic. We can refer out, but this is typically out of pocket. So you can, there's a psychologist that will do this for adults and might see some teenagers. You can pay for like an online class and do that. But what I typically ask parents and their adolescents to do first is try the CBTI Coach app. So this was made by the VA, and it kind of walks you through the principles of CBTI. And I ask families to set aside, 5 or 10 minutes after dinner, not right before bedtime, but after dinner, to kind of go through this app and use the features that it has. It's pretty easy to use, and so that's generally what I recommend. And then I might also ask for, or do some more parental education and ask them to kind of provide some more oversight for adolescent sleep. All right. So we're going to talk about pharmacological therapies now for insomnia. And I think it's important to know that there's no FDA-approved medications for insomnia. So we have, some smaller studies, some uncontrolled studies that help us, that might speak to the safety of the medicine in children and give us an idea about dosing. But it's a little bit harder to say exactly if these are efficacious over placebo for some of these medicines. And so I think it's important to use insomnia medications with a goal to kind of tailor them around the patient. So thinking about the medicine and its side effects and thinking about the patient and their kind of patient profile and their comorbidities is really the best route to go. So we'll start with melatonin. So this seems to be a safe and effective medicine when recommended by a physician. It works by kind of dampening your circadian alerting system, helping to lower core body temperature and promote sleep. Most studies used around 1 to 10 milligrams, so that's generally kind of the amount that I try to stay within. And we have some pretty good studies showing that it improved sleep onset latency and total sleep time. And we have studies importantly, I think in autism and ADHD as well, that this is effective. That's an important thing to remember and let our families know that we have looked at this in autism and other neurodevelopmental disabilities. And I wanted to bring up that, so this fall, the American Academy of Sleep Medicine released this statement kind of about melatonin, and it got picked up on the news. And so I get a lot of families coming to me asking, like, is melatonin safe? Can I give this to my kids? And so what the AASM was getting after is that they were talking about this CDC finding that in the last 10 years, the annual melatonin ingestion increased 530%. And so their statement about melatonin is that, again, it is safe and effective when recommended by a physician. And they're trying to get at, the use of over-the-counter melatonin when not recommended by a physician. And I think kind of generally people's attitudes that, melatonin is just a supplement that I can take, and it comes in all these good, yummy gummies and liquids. And so if you don't treat it as a medicine and you allow your kids to have access to it, there's that increased risk of ingestion. I think that's an important thing to point out as your patients might ask. And then we've got the melatonin receptor agonist here as well. So Ramelteon is one example. So these target the melatonin 1 and 2 receptors in the SCN. And there was a small study using this in adolescents that seemed to show that it was safe and effective. They used the adult dosing, 4 to 8 milligrams, and they showed some improved sleep quality. But I don't use this too commonly just due to kind of insurance and kind of expense problems with it. All right, so antihistamines. So we're really talking about the first generation histamine receptor antagonists. So commonly diphenhydramine and hydroxyzine have been used. And these are some of the most prescribed medications in like general clinics for pediatric insomnia, but a lot of pediatricians will reach for first. And interestingly, despite that, we have kind of not great studies to suggest that these are effective. So I found 2 randomized control trials actually of diphenhydramine that showed it did not perform any better than placebo. And then I found a small study looking at hydroxyzine, and they were actually using it to see if it would be helpful for sedation for EEG purposes. And they did show that hydroxyzine over nothing, more kids achieved stage 2 sleep. But still, we don't have kind of great evidence that this is helpful. And side effects, we can kind of think about our typical anticholinergic side effects for this. Alpha-2 agonists, so really clonidine is the medicine that I will use in this class. And this works to promote sleep by decreasing noradrenergic activity. And we have studies that show it improves sleep onset and sleep quality, and particularly in ADHD population, this seems to be helpful. It does decrease REM sleep slightly, and you can kind of see the typical dose ranges. And then I tend to warn families about not stopping this abruptly due to concern for rebound hypertension. All right, so benzodiazepines and then the non-benzodiazepine sedative hypnotics. So these work by promoting GABA inhibition and allowing for sleep. I think probably the most common one used in pediatrics would be clonazepam. But we really have, our adult literature showing that this has some cognitive impairment, some dependence, and then read on insomnia as well, which can be quite problematic. So this is not one I use commonly, but I think it's worthwhile to consider in some of the special populations. So thinking about kids that have refractory epilepsy or really severe parasomnias, or potentially in something like Angelman syndrome when they have both severe insomnia and often have difficult to control epilepsy. So I think there is a role for it in kind of those special populations. And then the non-benzodiazepine sedative hypnotics. So these are the Z drugs. You can think of Ambien, Lunesta. They bind GABA as well, but a little bit more selectively. And with that, there's supposed to be less dependence. However, some of the studies that have been done in children don't seem to support or find the same findings that they did in adults. So there was a randomized control trial that really showed no improvement over placebo for Ambien. All right, so gabapentin is kind of out here in a class of its own. So it's an alpha-2 delta subunit of the voltage-gated calcium channels, and it seems to exert its sedative effects through decreasing noradrenergic activity. It does help promote slow-wave sleep, and it decreases wake after sleep onset. So if you have somebody that has particular problems with maintaining sleep through the night and has a lot of nocturnal awakenings, this could be helpful. Often started at around 5 milligrams and titrated up. This can be associated with some dizziness and some agitation or depression. And we have some small studies looking at kind of case cohort studies looking at gabapentin in kids with autism, and it does seem to be helpful. All right, and so we'll move now into antidepressants, starting with the tricyclic antidepressants. So amitriptyline is commonly used for pediatric insomnia, and despite that, we really don't have a lot of studies looking at it for the indication of insomnia. However, we can kind of extrapolate studies from pediatric migraine or anxiety. And so we tend to kind of use lower doses of amitriptyline. It does seem to be helpful for sleep onset, particularly. And then interesting, doxepin is another tricyclic antidepressant that probably doesn't get used as much for anything else, but can be helpful in sleep. So it has more potent antihistaminergic properties. And in studies in kids, it does seem to improve sleep quality when used at low doses, like 2 to 10 grams. Overall, tricyclic antidepressants tend to reduce slow-wave sleep and REM sleeps. All right, and then our atypical antidepressants. So trazodone, which is a serotonin antagonist and rehab uptake inhibitor, it seems to have most of its sedative effects from that serotonin antagonism. We do have some studies of looking at insomnia in depressed adolescents, and it did seem to help with that. Trazodone does increase slow-wave sleep. And then there's just a few more kind of unusual side effects to be aware of, like priapism. Right, and then mirtazapine is a noradrenergic and specific serotonergic antidepressant. And at low doses, it really has some antihistamine properties. And so we utilize that for sleep. And so giving it at low doses can be very helpful for sleep. And for mirtazapine, we have a couple studies. There's an open label study looking at it for kids with autism that seemed to be helpful and had minimal side effects. And then actually, at Vanderbilt, we did a study looking at kids with Angelman syndrome on mirtazapine, and again, it seemed to be helpful with most tolerating the medicine well. All right, atypical antipsychotics. So I just put quetiapine on here. That's probably the most sedating one. It has its sedative effects through histamine and serotonin antagonism. It has been shown to increase some slow-wave sleep. And at least there was an open label trial looking at adolescents that had autism and aggression that were placed on this medicine. And one of the reported benefits was having less sleep. So in the right population, this could be helpful for sleep. All right. And then our last medicine is the orexin receptor antagonist. So these are new medicines. Sevorexant is the one that's been out on the market the longest. This is Belsomra. It was released in 2014 for the treatment of adult insomnia. It's a dual orexin receptor antagonist, and so we can remember, again, orexin or hypocretin is what's kind of destroyed in narcolepsy. So if we antagonize that receptor, we'll get sleepy like patients with narcolepsy. It increases REM sleep and has been shown to decrease wake after sleep onset. So again, a nice medicine if somebody is having nocturnal awakenings in the night. And there's a small open label trial using this for adolescents. They used pretty much adult dosing, 5 to 20 milligrams. It showed it was well tolerated and did seem to improve sleep. And again, I think the biggest issue with some of these newer medicines that we have for insomnia is the cost and issues getting insurance to pick up any of that cost. The lowest dose, 5 milligrams of Belsomra, is $400 a month. Great. So after going through all those medications, I wanted to bring up the idea of medication fading. This is something that I hear a lot from families. You know, melatonin worked for a period of time, and now it's not working anymore. Or the trazodone worked, and we went up on the dose, and then, you know, had to keep chasing it, and then now it's not working at all. And so I try to introduce this idea of cycling to my patients, that we may use medicines for periods of time, and if they become ineffective, come off of them, but kind of keep them in our back pocket to consider using again. And then another option, as somebody is sleeping better, would be to go to kind of weaning off the medicine and using it as a PRN basis. All right, so let's come back to our case. So again, our 3-year-old with autism. So we are seeing him at follow-up visit today, and the family worked really hard into the graduated extinction, and he's sleeping through the night. So we're very excited about that. He's got a nice daytime routine where his wake time is anchored at that 7 a.m. wake up. They're kind of powering through the morning, and he's sleeping a couple hours in the afternoon. That all looks very appropriate. Unfortunately, we have a new problem. The melatonin is not seeming to be very effective now, so he's having trouble falling asleep. They do a nice hour-long bedtime routine. They have the TV on the loop still, and the parent no longer pats or stays in the room while the child is going to sleep. But despite going up onto 6 milligrams of melatonin, the child takes about an hour to fall asleep and keeps trying to leave the room. Okay, so I think, you know, what would we recommend next? So again, some behavioral recommendations, thinking about parental education and talking about sleep hygiene a little bit more. So for this family, I got this from one of our behavioral psychologists at Vanderbilt, but I would ask the family to first put like a sheet over the TV and leave it on the loop. And so that child is still, you know, gets some light from the TV and is getting that kind of the sound that they're used to, but trying to kind of make it a little bit less interactive to help them sleep. And then I'd probably too talk about medication cycling for this family. So melatonin is not working right now, let's stop it, and we can always think about that again in the future. And then, you know, I think it's plus or minus whether you want to add some pharmacologic therapy. I think I probably would start clonidine on this patient to see if we can get them falling asleep faster as we tie in some of this parental education and behavioral recommendations. Alrighty, so take-home points for childhood insomnia. So I want you all to understand what normal sleep is, and I think that 2-process model of sleep is a really good one to keep in mind and talk to families about. And then the differences in pediatric sleep, so recognizing what is appropriate sleep in kids is important. And then I think the 3P model of insomnia is helpful one to think about when we're treating insomnia. So what is that predisposition? Are there precipitating events that we can pull out? And then what are the perpetuating factors that they're inadvertently doing to kind of keep them in that insomnia state? And then letting your sleep history kind of guide what recommendations you give. So whether that be a further workup and potentially a referral for kind of evaluation for other sleep disorders, or kind of tailoring your behavioral recommendations to the type of insomnia that you're hearing about or the age of the patient, I think is very helpful. And it kind of saves you some work because you're not going through everything, and saves the parent a little bit of work too. And then, you know, we have these medications that we talked about if you end up needing to kind of pair medicines. All right, so here are my references, and then I'm happy to answer any questions, or if you guys have a favorite family-friendly hiking spot in Kentucky, I'd love to take those. This is my family near Swanee, Tennessee this spring.
Dr. Singer, I have a question.
Yeah.
So for patients where you're trying the behavioral therapy as well as the pharmacology, kind of bridging that, how long do you kind of give it a shot before you think, okay, this pharmacologic therapy isn't working or this behavioral therapy isn't working? Because then you're going to be like, this bridge is going to be might be prolonged. Is it short? At what point do we consider like changing the therapies involved?
That's a good question. So the question was, how long do you recommend trying either behavioral therapy or pharmacologic therapy before you kind of reevaluate what you're doing? So I really ask patients to try to do this for several weeks. And I talk about, like, think about how long you've had insomnia. Like, to work out of this, it's going to take time. And so I encourage them to give it several weeks of really kind of, and it's effortful, like working on this and doing the behavioral therapies. When we think about how they offer CBTI in adults, they are doing, it's kind of intensive. It's 6 sessions, but they're each an hour, and they're offering this typically over a couple weeks. And so I try to kind of mirror that because that is evidence-based. And so.
Kelly, no, sorry, Emily, can I add on? So, that is actually if you have a proper, the sleep psychologist, usually, 6 to 8 week session. There are some more an advantage of just starting CBTA alone first, versus if you start the combination of CBTA and medication. If you start on medication, then the CBTI effect will be, the input of the patient will be very less. So there is a pros and cons on both sides. But usually, as Kelly said, that 6 to 8 weeks actually, and given the real full-fledged, like a big program, they have a sleep psychologist. They give a very intense therapy for 6 to 8 weeks. If they fail, then they go with the medication.
Hi, Emily. So thanks for that talk. Thank you very much. So, given, the number of children that we have with sleep issues and the significance of this, of cognitive behavior therapy, are we, what is the importance of having a sleep psychologist in a program like ours?
I think that's a great question, and it's something that Dr. Centaville and I have actually talked about a lot in the last month, and I know it's something that he's worked on really a lot. It's so important, and it can make all the difference in kind of compliance that the families have, getting that support. So I got to kind of shadow a sleep psychologist, a behavioral sleep psychologist in pediatrics in my fellowship. And, their intake, that first session with the family is, 90 minutes long. And then they have, repeated visits with them and really intensive working with the family to develop an individualized approach for insomnia. And those families, we've shown that they do a lot better with that resource.
Emily, can you comment on the effects of insomnia in a child on the well-being of the family, of the mother, of the father in the family, of the other children, on their mental well-being, on their physical well-being? What is the impact of insomnia on a family?
Yeah, that's a great question. So they've looked at this, and there are higher rates of depression, maternal depression for children that have insomnia. They've shown problems with just family functioning in general, and especially for our kids that have neurodevelopmental disabilities. We've shown that insomnia tends to be lifelong. Some typically developing kids, this might be kind of a period in their life that they then grow out of, and then the family can kind of recover their sleep somewhat. But it's not always true for kids with autism and things like that. And then also we have to think about those parents might be caregivers for that patient's entire life. And so we really need to kind of think about that. And I think that's why it's part of the insomnia definition, that impairments in family functioning. Arpita, to answer your question on the chat about like resources, so I have some of my own like smart texts that I'd be happy to share. I sometimes direct parents to sleepfoundation.org. I like kind of, it's pretty kind of patient family friendly information. And I think what's hard is that when you start to look up, like just start Googling like sleep interventions, there's a million different things. And a lot of them are things that, you know, they can be paid for to help your baby. So I try to kind of offer them that Sleep Foundation website or some of my own materials. And I don't know, Dr. Somerville, if you have some that you particularly like to share with families. Great. Well, thank you all for your attention. Thank you.
Thank you very much.
To include other people, it's just me and Karen. I swear to God.
Thank you guys.
Thank you. Yeah, thanks for coming.
Okay, is it all there?
Great. So I know that. Yeah, thank you for all your help.
Oh, it's supposed to be.
And actually, I know it was hard to get everything started, but the timing ended up working out well.
Yeah. Thank you so much. It was a little bit. And Dr. Puri was trying to find this link and
I
then
know.
just send him text message as a picture, and he kind of like, no, send me actual link. And I tried to do it, and connection not working. You don't hear it.
Yeah, the
So
internet
not good. And he started following Dr. Palari, Dr. Latosha, and everybody kind of like,
Goodness. Well, there's always something, especially in a new room. So.
Yeah, especially in this new room. I will get the copy. Would you like to have a copy of your lecture?
No, that's okay.
That's okay.
Yeah, it'll go.
Dominic will probably post on YouTube,
Yeah.
Neurology YouTube.
Great. That'll be perfect. I'd be glad to have it there.
Yes.
Okay.
Thank you so much.
Yeah, thank you.
And if you will share with me a link about this rental course.
Oh, yeah, I will send it to you. Yeah.
Love to, because I never heard about this. This is kind of like really cool.
It is. I really like it. So I'll send it to you.
Okay.
Yeah.
All right. Have a wonderful day.
Same to you.
See
Have a
a
good
patient
one.
today?
Yeah, I'm going over to clinic.
Okay.
So, I might have one waiting. So.
Probably.
Yes.
Yeah. Thank you so
Bye.
much.
Thank you.
Bye.
I said, take some initiative. Then I don't, why should I play? Hey, I am not seeing it.
I love how many people triple.
Oh.